Tachycardia treatment. We're mainly going to focus on the narrow complex tachycardia treatment in this lecture. We're going to treat stable narrow complex tachycardias using the AHA tachycardia with a pulse algorithm and treat unstable narrow complex tachycardias using the AHA tachycardia with a pulse algorithm. So our treatment can vary based on the hemodynamic stability of the body. But if they are hemodynamically stable, we're going to consider using vagal maneuvers. So vagal maneuvers, also called Valsalva maneuvers, are going to stimulate the vagal nerve, which releases acetylcholine, which results in slowing of the heart rate. The acetylcholine sends a message to the SA node and says, hey, slow down. This is achieved by bearing down like you're going to have a bowel movement, forcefully coughing against a closed glottis, squatting. There's even carotid sinus massage. One thing that I like to do is give a patient a syringe and pull it out just a little bit, give it to them, and tell them to try to blow the plunger out of the syringe. And this actually creates a back pressure that will help create a vagal maneuver. Drug therapy, which includes adenosine, and then also electrical therapy, which includes synchronized cardioversion. But one very important question to ask when we're talking about tachycardia treatment, especially if it's a higher sinus tachycardia, are the symptoms being caused by the tachycardia? If the symptoms are being caused by the tachycardia, then treat the tachycardia. But if it's other symptoms that are actually causing the tachycardia, we're going to have to treat the underlying cause. So patients with unstable tachycardia should be treated immediately with synchronized cardioversion. If a pulseless tachycardia is present, patients should be treated using the pulseless arrest algorithm. Decide on the seriousness of the symptoms. If it's a stable tachycardia, like we mentioned, vagal maneuvers and medications are recommended. If it's unstable, then electrical therapy is going to be our go-to treatment. So looking at the American Heart Association Adult Tachycardia with a Pulse algorithm, we're going to take a look at the treatments. So we've decided that we're going to treat a patient with the tachycardia. So one thing that we need to first determine is, are they experiencing any of these? Hypotension, acutely altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure. So I call this the pink box of death. So there only has to be one of these listed, and we're going to answer yes to that question, because that means that they are hemodynamically unstable. So we're going to go straight to synchronized cardioversion. Now, the recommendation for your joules dosage for synchronized cardioversion is going to be based on the monitor that you use, whether it's a Zoll or a LifePak or a Philips or some of the many other brands. So you certainly want to check with your agency or your protocols to figure out what dosage you're going to use. But for today's purposes, we're going to go with the original American Heart Association recommendations as far as the joules dosage. So for a narrow regular is going to be 50 to 100 joules. For a narrow irregular is going to be 120 to 200 joules. Now, one important thing to remember before you cardiovert, if they are hemodynamically unstable, but they can tolerate it, this patient should be sedated with using a benzo such as Versed or Valium or something like that, or you can also consider using a narcotic such as fentanyl. Now, once we shock, if it's refractory, consider what's causing it. Is there a need to increase the energy level for the next cardioversion, which is usually what it's going to be, or you could even add an antiarrhythmic drug. Most likely it'll be amiodarone. Now, moving back to the pink box of death. Let's say that we answered no to these questions. So then they would be considered hemodynamically stable and we could move down to the next box. Now, once we hit this box, we got to determine, is it a wide or narrow complex tachycardia? Now, for today's purpose, we're only talking about the narrow complex, so we're going to say it is a narrow complex tachycardia with a heart rate or a QRS less than 0.12 seconds. So the first thing we may try is vagal maneuvers. The second thing that we may try is adenosine. So adenosine, your first dose is 6 milligrams rapid IV push, followed by a normal saline flush. It should be followed by 20 milliliters of normal saline flush. And your second dose, if required, is 12 milligrams. Then we can consider a beta blocker. Beta blockers such as sotalol, as is listed here, or whatever beta blocker IV form that you may have on your ambulance. And also calcium channel blockers. A really good calcium channel blocker would be diltiazem. So we want to try medications first. Also, a very strong point here is that if you're going to give adenosine to a patient, you want to make sure that you go ahead and let them know what's going on and that they may not feel very good while they're receiving that medication, because there is a chance that it may stop the heart because it is a medication that targets the AV node, and it actually may have a period of asystole before it hopefully converts. So medications for tachycardia treatment include adenosine, diltiazem, certain beta blockers, amiodarone, digoxin, verapamil, and then magnesium for your torsades de pointes. So adenosine should be used within the tachycardia algorithm when vagal maneuvers fail to terminate stable narrow complex SVT. So if you remember from the AVNRT lecture, we said that we're going to treat any narrow complex tachyarrhythmia as AVNRT until proven otherwise, and adenosine should hopefully work for AVNRT. Adenosine, again, is the primary drug used in the treatment of stable narrow complex SVT. When given as a rapid IV bolus, adenosine slows cardiac conduction, particularly affecting conduction through the AV node. The rapid bolus of adenosine also interrupts reentry pathways such as those with AVNRT. So just like I mentioned in the algorithm, the first dose of adenosine should be 6 milligrams administered rapidly over 1 to 3 seconds. The rapid administration is very important because the half-life is very, very short, and it may already be metabolized before it even reaches the patient's heart. If the patient's rhythm does not convert out of SVT within 1 to 2 minutes, we can consider a second dose of 12 milligrams. So diltiazem, also known as cardizem, is a calcium channel blocker. Now, it slows conduction at the AV node. It also decreases automaticity of ectopic foci. So this drug could be used in other tachyarrhythmias as well, other than just AVNRT. And it decreases the velocity of cardiac contraction, which is also known as dromotropy. One thing to warn you on, though. With cardizem, it causes peripheral vasodilation, so we've got to pay attention to their blood pressure. It could cause the patient's blood pressure to drop, and they could become very hypotensive. It also controls ventricular response rates in atrial fibrillation and flutter and multifocal atrial tachycardias. So the accepted standard dose is 0.25 milligrams per kilogram IV. The beta blocker here that we'll talk about is sotalol, because it's on the American Heart Association algorithm. Sotalol is a non-selective beta-adrenergic blocking agent used to treat ventricular and supraventricular dysrhythmias. Now, not only is it a beta blocker, but it's also a type 3 antidysrhythmic, which happens to be in the same class as amiodarone. So a class 3 antiarrhythmic is used to treat both supraventricular arrhythmias and ventricular arrhythmias. Now notice here, your dosage is different than on your cardiac arrest algorithm. Your dosage for your tachycardia with a pulse for amiodarone is 150 milligram infusion bolus over 10 minutes. So you should have focused treatment on your narrow complex SVTs. You should focus on identification of the arrhythmia and understand, is this patient hemodynamically stable or unstable? But understanding the mechanisms involved will help you to identify these SVTs and to further treat your patient.